Hi, I'm Susan.
I'm Melissa.
I'm Annalise.
And I'm Travis.
And today we're going to be talking about cervical spinal cord injuries. Cervical spinal cord injuries, or CSCIs, affect approximately 10,300 new Americans each year. Between 247,000 and 358,000 people in the US currently have a spinal cord injury, with 58.7% of those being from the cervical region. On the next slide, we can see that most CSCIs occur as the result of a motor vehicle accident. More than half occur from other traumatic incidents. These tend to be disproportionately affecting young males in the prime of their life. Non-traumatic causes of CSCIs include anything that can damage the nerves traveling through the spinal cord, such as birth defects, tumors, or stenosis.
Diagnosis typically occurs in the emergency room via x-rays to reveal tumors, vertebral problems, fractures, or degeneration. CT scans are used, which are essentially a series of multi-layer x-rays and therefore have better definition of soft tissue. And MRIs are used, which are helpful for identifying herniated discs, blood clots, or other masses.
The ASIA scale is one that some of us are probably familiar with and was written by the American Spinal Injury Association. It has a series of sensory and motor tests that are used to define and describe the extent and severity of a patient's spinal cord injury. This is helpful to determine future rehab and recovery needs and is ideally done within the first 72 hours of injury. It's scaled from grades A to E, A being complete lack of motor and sensory function below the level of injury, and grade E being all neurologic function has returned, with various degrees of function in between. This is one of the most popular ways the extent of a SCI is determined.
As a quick review, let's look at what travels through the 7 cervical vertebrae. Posteriorly, seen in dark blue and turquoise, are the dorsal column medial meniscus, which carries sensation of touch, vibration, and proprioception from the same side of the body. Laterally, in red, are spinal thalamic tracts that carry nociception, pressure, and temperature from the opposite side of the body. In yellow, we see the spinocerebellar tracts carrying nerves that help to coordinate movement to the cerebellum. But often in spinal cord injuries, these are masked by damage to the motor neurons that travel through the corticospinal tract from the brain to the muscles. Observing patterns of deficits in sensory and motor functioning is part of the diagnostic process.
So while we talk about damage to spinal level as resulting in deficits to that level and everything below it, like, so for example, if we say, oh, they got their injury at C5, then everything at C5 and below isn't going to function. That's not quite true. That would be assuming a complete injury, like the equivalent of as if you transected the spinal cord. Many injuries are incomplete, so the portions of the spinal cord tracts that remain intact will allow for some residual sensory and motor function to be retained, and that is what we can improve upon with skilled PT interventions. Injury to spinal level C1 through C4 is generally referred to as high cervical injuries, and the additional deficits that you may see here are difficulty with breathing, and if this is severe enough, the patient may require mechanical ventilation in order to breathe, as well as difficulty speaking, coughing, clearing saliva, or moving the neck. As an example, an injury at C1 will be most severe and will likely show a complete inability to move the neck or to depress the hyoid bone for swallowing and speaking, while injuries at C2 to C4 will likely leave patients with some of these functions. However, it is important to note that patients with injuries at any of these levels will need 24/7 assistance for ADLs, but they may be able to achieve some mobility using specialized power wheelchairs. So C5 through C8 represents the remaining levels of the cervical spinal cord. A defining feature of injuries here is that patients will still retain some use of their arms and shoulders, and for this reason, they may be able to drive adaptive cars and perform ADLs with some level of independence. There are some meaningful differences between injuries at each of these levels, so we will briefly discuss each one. Although patients with a C5 injury may have some difficulty with speech due to weakened control over the vocal cords, they can usually still breathe without assistance and may retain control over the deltoids and the elbow flexors.
A C6 injury means the patient will be able to breathe on their own, although it will be weakened. Paralysis in a patient's hand, trunk, and legs is present, but they can move their arms. They can flex but not extend their wrists. And with assistive equipment, they may be able to move in and out of bed on their own. Here we see a young woman with a C7 injury using a phenomenon called tenodesis to perform a daily task. Although they don't have control over their grasping muscles, they use passive tension by extending their wrist to pick things up. And of course, C8 injury is the lowest level of the cervical spinal injuries. And when we reach this level, we see that patients have full use of their upper extremity, including their grip.
The critical stage is broken up into primary injury and secondary injury. The primary injury is the rapid spinal cord compression and contusion. During this time, survival is key. Because of this, the typically traumatic mechanism of injury, the responsibility falls on emergency medical services. Their main goal is to immobilize the patient to prevent further damage, and especially to avoid duplicating the directional mechanism of injury. EMS usually transfers a patient to a level 1 trauma center if possible. The secondary injury is a cascade of events downstream that occur as a result of the primary injury. Preventing and mitigating these secondary mechanisms is where opportunity for neuroprotection lies. The acute phase is typically defined as the first 72 hours. In this time, decompression surgery is usually done to reduce pressure on the spinal cord. Decompression surgery usually consists of either a laminectomy, total removal of the lamina, or a laminotomy, partial removal of the lamina. Fusion surgeries often accompany a decompression surgery because decompression surgery requires the removal of bone and tissue, causing the spine to be less stable. The instrumentation acts to stabilize, support, and realign the spine. This consists of rods, screws, plates, or cages. During a fusion surgery, an autograft, meaning the patient's bone, or an allograft, meaning a donor bone, is used. These are used to stimulate bone growth and healing. In addition to these options, synthetic materials such as ceramic or cement have successfully been used.
There are many acute complications that can occur as a result of a cervical spinal cord injury. Some of the most common and potentially fatal ones include autonomic dysreflexia, which is essentially uncontrolled increase in blood pressure and can sometimes be accompanied with bradycardia. It is seen in about 90% of patients with complete cervical spinal cord injuries, and they could have hypertensive episodes about 40 times a day. These are potentially fatal because they can increase the risk of stroke by 3 to 4 times. Autonomic dysreflexia often occurs as a result of urogenital complications, such as UTIs, bladder distension, or catheter blockages. These episodes occur because of disruption to the supraspinal control of sympathetic preganglionic neurons that regulate blood pressure. And when this regulation is lost, these neurons become susceptible to hyperactivity and stimulation below the level of injury. Neurogenic shock is another complication that can occur and is a similar phenomenon, but is severe hypotension, systolic blood pressure lower than 90 millimeters of mercury, as well as bradycardia. Essentially, neurogenic shock develops as the parasympathetic system outweighs the sympathetic system.
According to Dr. Charles Tater, final outcomes of spinal cord injury depend upon accuracy, adequacy, and speed of first aid management, diagnosis, and treatment within the first few hours. A study done in 2012 tested the difference between early decompression surgery, less than 24 hours post-injury, and late decompression surgery, greater than 24 hours post-injury, in regards to traumatic cervical spinal cord injuries. The Asia Impairment Scale was used as an objective measure in this case, and of the 222 participants able to complete the 6-month follow-up survey, 19.8% of the early decompression patients showed a greater than or equal to 2 AIS score improvement when compared to only 8.8% of the late decompression group. In addition, 24.2% of the early decompression patients experienced complication, whereas 30.5% of the late decompression patients experienced complications. It should be noted that all decompression surgeries were accompanied by an instrumented fusion procedure. The subacute stage lasts an average of about 6 to 12 weeks, and the primary goal during this time is to avoid further complications. An emphasis is put on passive range of motion and stretching in order to avoid further complications, such as contractures, atrophy, and pain. These are done by the PT and OT in the hospital. Patient comfort is also important and can be accomplished by pillow arrangement and other adaptive equipment. In terms of patient equipment you may see while in the hospital, there could be an IV giving hydration and medicine, a catheter to aid in urination since they have lost control of urination, compression stockings to prevent edema and DVT, endotracheal tube and ventilator to assist in breathing, and a nasogastric feeding tube traveling from the nose to the stomach. The healthcare team typically consists of a physical therapist to help strengthen, improve or maintain range of motion, prevent atrophy, and perform transfers. Occupational therapists aid in teaching adaptations for activities of daily living and fine motor skills. There's an MD for general care, a respiratory therapist if needed, and a psychologist for mental health. It's also important that all of these people are involved in adapting the home later on. Prior to discharge from an inpatient facility, the healthcare team must confirm the patient's home is equipped with the necessary adaptive equipment. This equipment allows the patient to be as independent as possible with their ADLs. These home adaptations include widened doorways, wheelchair ramps, hardwood floors, modified tubs or showers, lowered counters, sinks, and mirrors, specialized lifts, proper eating utensils, uniquely shaped door handles for leverage, and the caregivers must work closely with the therapist and the healthcare team to ensure that they are properly trained in transfers, exercises, and ADLs. If you look at the photos here, the bottom left shows a handle that has a loop for it for the patient to be able to loop their wrist in and pull due to the fact that they lack the dexterity to usually grasp a handle. Same thing goes for the spoon to the right of that. There's a strap that wraps around the hand and it just allows them to be able to feed themselves. Next picture is actually a stylus for iPads or screens when driving that's adapted as a ring for the patient. As you can see, there's a ramp going into the home for the electric wheelchair, and then a lift up above to aid in transfers.
So there's many complications that can occur as a result of cervical spinal cord injuries, but some of the most common are respiratory disorders, as well as dysphagia, thermoregulation disturbances, pressure sores, and depression or anxiety. As you can see, there's some overlap with some of the acute complications because it's really just going to depend on the severity of the patient as well as where they are in their injury timeline. So respiratory complications are the leading cause of death in cervical spinal cord injuries, affecting 84% of those with high cervical injury. These are mostly in the acute hospitalization phase, with primarily being atelectasis at 36%, pneumonia at 31%, and ventilatory failure at 22%. Pneumonia is one of the most common respiratory complications involved. However, the use of ventilators is an interesting aspect that could be linked to its involvement. A study by Hatton et al. Examined ventilators using high tidal volume ventilation for cervical spinal cord injury rehab. In the study, it discovered that ventilator-associated pneumonia was found in about 68% of patients using high tidal volume, leading to almost a twofold risk of pneumonia development, and was also associated with increased rates of ventilator dependence. Dysphagia, as we see here, is another disorder that is very common. Dysphagia is a disorder that compromises swallowing function, where food or liquid cannot properly move from the oral cavity to the esophagus. Under normal circumstances, the brainstem swallowing network receives descending signals from the cerebral cortex and then begins the swallowing cascade, which utilizes various cortical and subcortical pathways. Dysphagia can be present in many clinical populations that we've already learned about, such as stroke or Parkinson's disease. However, overwhelmingly affects those with cervical spinal cord injuries at about a 41% prevalence. Serious complications can occur as a result of dysphagia, such as malnutrition, hypoxemia, decreased communication, and even death. So it's definitely a serious disorder that we need to make sure that we're managing properly. Another aspect that can be compromised in those with cervical spinal cord injuries is thermoregulation. When these abilities are lost, it's difficult for patients to sense temperature changes, and they should avoid extreme temperatures and also heat packs and ice packs. After injury, the energy expenditure of a patient decreases about 10% due to reduction in lean body mass. Patients begin losing muscle mass and gaining fat mass. This subcutaneous fat mass affects heat conduction, causing an imbalance between core and skin temperature. The inability to maintain homeostasis is mostly due to the decreased sensory input to thermoregulating centers of the brain, as well as the loss of sympathetic control of temperature and sweat regulation. Lastly, another aspect that we need to make sure we're monitoring is pressure source. With about 7.5% of trauma patients being cervical spinal cord injuries, the risk of bed sores is high and increases further with immobilizing devices, as well as ICU admission, high injury severity score, and mechanical ventilation. Pressure sores are a common byproduct of hospitalization. However, they are not without serious side effects, such as increased healthcare costs, as well as pain, mortality, and decreased social and psychological well-being.
Not surprisingly, depression and anxiety are a major concern for this population. The rate of depression and anxiety is 2 to 3 times higher, and the prevalence of suicidal thoughts up to 6 times higher in those with cervical spinal injuries. In addition to traditional treatment, mindfulness-based interventions have been shown to improve anxiety and depression. Especially if telehealth appointments are utilized, this leads to better compliance and therefore better outcomes. While researching depression rates for quadriplegics and paraplegics, I found a story from 2010 about a young man named Dan Cruz. He lived in Michigan, which is a right to die state, if a doctor approves it. But his doctors all said he was too depressed to make this decision. In the article, he describes having no life. His mom, who is the primary caretaker since his initial motor vehicle injury when he was 3 years old, described him as helpless. He had access to a computer he could operate with a mouthpiece, but he spent his days in a dark room, in bed. His round-the-clock care had drained the finances, and he was facing losing his home. It was not a surprise that he was depressed. Although I searched for follow-up articles, all I could find were reports of community outreach and people writing him letters of support, but there was no information of what had become of him. What is clear from his story is the need for a person to still feel relevant, to believe that he or she can contribute to society, and the need for some measure of autonomy and hope. The following treatments and adaptive equipment aim to help in this endeavor. But perhaps the most important tool that we as future PTs will ever give our patients and their families is a sense that their lives can still be rich and meaningful. The first line of treatment advances are in the area of the acute phase of recovery. While methylprednisolone is approved for use to suppress secondary injury caused by the inflammatory response, unless it is administered in the first 8 hours after injury, it dangerously increases the risk for fatal pneumonia and other infections. So its use is controversial. Some promising research has been done in animal studies using hepatocyte growth factor, or HGF. It is applied directly to the injured spinal nerves. Systematic review from January of 2020 by Kitamura et al. Saw a significant increase in healing and regeneration of injured neurons, a reduction of astrocyte activity and glial scar formation, as well as localized anti-inflammatory effects. In one marmoset study, hand function was even restored after administering recombinant human HGF to the injured spinal cord.
Aside from pharmaceutical intervention, another area of developing advancements is in adaptive cars. You cannot be denied the opportunity to apply for a permit or license because you have a disability, but you may receive a restricted license based on the adaptive devices needed. The driving evaluation includes vision screening and muscle tests, flexibility and range of motion, hand-eye coordination and reaction time test, judgment and decision-making, evaluation of medication, and the ability to handle the adaptive equipment itself. Some of the common adaptations include hand controls for braking and accelerating, power assist devices for steering, touch ignition and gear shifts, and joysticks, to name a few. Joysticks are primarily used for those with limited hand function. A joystick system will run upwards of $40,000 to $65,000 plus the cost of the van or car that they choose. The cost of modifying a vehicle varies greatly. The average cost of modifications plus the car or van itself varies anywhere from $20,000 to $80,000. In fact, many popular car brands offer discounts of up to $1,000 to put towards modifications of their vehicles. So one person that I wanted to highlight in my research was Mario Boniface Jr. He was 17 when he flipped over the handlebars of his dirt bike, causing a cervical spinal cord injury. He lost most of the use of his arms, but still regained some shoulder mobility and wrist extension. Though he was still getting used to his new abilities, he still had a need for speed and set out to figure out a way to achieve it. Motorcycles were his first love, but seemed out of reach, so he set out to adapt a race car. With no engineering background, he was able to design a steering wheel that would allow him to control a race car at speeds upwards of 100 miles per hour. The steering wheel was rectangular in shape and spring-loaded for control. He pushes his left hand grip to brake and twists the right hand grip to throttle, just like a motorcycle. Shifting gears is done by micro pushes and pulls on the right side.
Keep chasing the dream until it's reality.
Mario is just one of the many stories of people who turn their remaining abilities into action.
Another hot topic intervention for spinal cord injury patients is robotics and brain-computer interface, or BCI. We've already seen much of the progression of BCI mad science through the videos that Dr. Buija showed us in class, from BCI in monkeys and then in humans. Here we will look at an example for each of the two major approaches used in research today, and then end with a twist that may be even more promising. Current BCI research has involved implanting microelectrode arrays, or MEAs, into the primary motor cortex to decode movement instructions, which is then sent and analyzed by a computer and then sent to a robotic arm to produce the desired movements, or through e-stim apparatuses to stimulate the patient's own muscles. The first major approach is to use BCI as an assistive device, where the patient would control robotic arms to assist them with their ADLs. These would likely have to be somehow attached at the shoulders or through some kind of portable system, which could, say, be attached to the patient's wheelchair. The Johns Hopkins University's Applied Physics Lab has developed a modular prosthetic limb, seen here in this video. As of 2019, this man with quadriplegia was able to simultaneously control 2 robotic arms at the same time, while also receiving limited touch sensations when the prosthetics were touched. Note that he has 3 different MEAs implanted into his skull, one for each primary motor cortex and one for a primary somatosensory cortex. While feed-forward information is used to control the movement of the robotic arms, there is also feedback sent from the robotic arm whenever it is touched, and this information is relayed to the corresponding area of the patient's sensory cortex. However, thus far this patient, who actually has some residual sensory and motor function in his arms, has noted that the sensations he has received are only somewhat similar to what he feels when his actual arm is touched. But this marks an important step because sensory feedback is critical to being able to effectively utilize motor output. For example, while it would be great if using the robotic arm allowed him to pick up a glass of water and move it to his mouth, it wouldn't be so great if he did this with too much force and ended up breaking the glass because he couldn't feel how strongly it was squeezing. So, successful integration of robotic arm sensation still needs much work. Regardless, this approach is already showing much promise. The second major approach is to use BCI as a spinal cord bypass. Since the spinal cord injury essentially represents a communication block between the brain and the muscles, we can try to bypass this block by providing an alternate pathway. Here at right, you see a sequence where a patient with C5, C6 quadriplegia was able to grasp, manipulate, and release objects using his paralyzed hand, and this was accomplished using an MEA combined with e-stim of multiple muscles. Instead of the MEA sending the info to a computer for analysis and then to a robotic arm to perform the movement, instead, multiple e-stims activate the patient's own muscles with the appropriate strength, duration, and rate to perform the desired movements. While both of these approaches are promising, the current major limitation is that they can't be used outside lab conditions, due in part to the bulk of the equipment and having the MEA sticking out of your head and directly attached to a computer. So, is there another option? The company Synchron has developed a stentrode, which is what we see here in this picture, which is basically a stent version of an MEA that integrates into the wall of a vein, the superior sagittal sinus in the brain, over about a week, where it's able to record and transmit data wirelessly. Here's a short video showing how they do this.
the catheter traveling up through different blood vessels into the brain. You can navigate the device up into the brain. We put it into a blood vessel called the sagittal sinus. This is in the middle of the brain. It sits on top of the motor cortex. And the device sits within the blood vessel. The device has electrodes around the outside. And these electrodes pick up the nerve activity from the motor cortex in the brain.
So some benefits to using this approach is that you don't need to break open the skull. You don't have to have an MEA sticking out of your skull and being directly attached to a computer. That part of the apparatus is bulky and not practical for home use. And then the creators who made this device think that it has the potential to last for the patient's lifetime, or at least as long as typical stents, compared to 5 years for having an MEA attached directly through the skull, because that directly touches the brain tissue and causes damage. The downside is that right now they only have one clinical trial, which is using this to convert thought to speech into digitally produced speech, like through an app on a phone or a computer. And this would be useful at least for patients with high cervical spinal cord injuries who are unable to speak. The creators do note, however, that although this device addresses the problems associated with the EMEA itself, there's still much work to be done for either of the two approaches we discussed to become feasible for home use. And that's where we're at now for robotics and BCI interventions for spinal cord injuries.
So why do we care? Since these injuries tend to affect people in the prime of their life, it's imperative that we, as healthcare providers, know how to help these patients achieve their best quality of life. Thank you for your time and attention this morning, and we look forward to your questions.